Good morning, good afternoon, good evening, wherever you are. Welcome to this MDS roundtable, which is run by Blood Cancers Today. It's a true pleasure to be with you today. My name is Amer Zeidan. I'm an associate professor of medicine at Yale University. And today we will be covering a lot of the exciting developments in the field of MDS. The last couple of years have seen important approvals and some important changes to the risk stratification as well as the classification of MDS. And to debate all of these new aspects, I'm joined today by three of my colleagues. All of them are top experts in MDS.
Hi, my name is David Swoboda. I'm the Director of Leukemia at Tampa General Cancer Institute.
I'm Jamie Koprivnikar. I'm at the John Theurer Cancer Center in Hackensack, New Jersey.
I'm Sangeetha Venugopal, Assistant Professor of Medicine in the Division of Hematology at University of Miami Sylvester Cancer Center.
Welcome to all of you. So David, we still have a lot of ESA used in the community. It's not going to go away. It's still going to be used in the frontline setting. But I think there are several kind of problems that I tend to see. I'm sure you see some of them, like in terms of how doctors use them. One of them that I have seen a lot is that people not checking EPO level. So they just get ESA regardless, even if the EPO level is very high, which you probably could argue for before we had other drugs, because otherwise what are you going to use? I think the second thing is continuing ESA even in the face of continued transfusion needs, like no improvement, but the patient might feel better and the doctor kind of just decides to continue, or suboptimal dosing. Like, what are some of those issues that you have seen in your clinic when people use ESA?
Yeah, no, I would say all of the above. We see a lot of suboptimal dosing. We see a lot of beyond people that are continue to become transfusion dependent, really never transfusion dependent, never really respond, and they're 3-6 months in. We also see patients that have increased blasts that are getting a lot of ESAs in combination with HMAs, which we really don't know, but generally most people are not doing that combination in higher risk myelodysplastic syndrome. I think it's tough. There's certain subsets of patients that I don't know if luspatercept or ESAs are the right option, and I'm not sure if we have any good options. And those are, in my mind, would be the patients with 4 or 5 mutations. If you have someone that has a lot of mutations, at least in the commands data, both luspatercept and ESA don't work. So then what is our options there? And I think hopefully some of the new drugs that are coming along the line will be available. But yeah, I think the suboptimal dosing is big, and sort of treating beyond benefit are two big things that we see. And we try to get people switched over to luspatercept and see if they'll respond, or other agents.